So Dr. Biju Raghavan is a senior consultant and the head of department of pain and palliative medicine in Rajagiri Hospital, which is one of the most prominent hospitals in Cochin, Kerala. He is from the first batch of the 2-year PG diploma in pain and palliative medicine program in the country. He did it 17 years ago, more than 17 years ago now. Sir has been extremely active in the field of palliative care. As you can see, he is a visiting faculty not only for us here in Trivandrum, but also in MNJ Institute of Oncology, Hyderabad, Department of Philosophy, Kerala University in Trivandrum, and now part of Rajagiri Hospital. Sir has got special interest in various areas, end-of-life care, oncology, respiratory, palliative care. But today, what you will be seeing is a master of communication. So what are the things which Sir has to share with us as far as communication is concerned? Sir, so just for a background, last 6 sessions, various cases were presented, various topics we went through, and every time a lot of questions is around how to deal with communicating some difficult information or taking the caregivers along the treatment pathway, things like that, which ends up in communication. So we have been saying that we'll be looking at it. Let's look at that in the coming sessions, etc. And so today is the day. Today and the next session are the day when we'll be looking into communication in detail from a palliative care perspective. And as you will be observing, this is not just from a palliative care perspective, but this is a value addition to any practicing physician. Over to you, sir.
Thank you, Sripriya. Thank you, Deepak, for the extremely kind introduction. And it's always a pleasure to associate with Pallium India. I've been part of Pallium India, working there for close to 9-10 years. But I've been with you all people since the inception of Pallium India. So it's a great pleasure and an honor to continue to maintain this great relationship. And yes, no doubt about that, communication skills are very, very important. Whether you're practicing palliative medicine or any kind of diagnostic or therapeutic areas of medicine, communication skills are very, very important. So this is just not only for practitioners of palliative medicine, but even if you choose to not practice palliative medicine or practice it part-time or even full-time, doesn't matter. This is going to be helpful for everybody. As Sripriya mentioned, we are going to do it in 2 parts. Today only part 1 will be attended to, and part 2 will be on another day. Today we'll be talking about basics of medical communication skills, and without much ado, I will start. I just wanted to ask the hosts, Sripriya and Dr. Deepak, should we have the case presentation first and the talk later, or the talk first and the case presentation later?
So we can
what
have
is
the
your
talk
format
first, sir. We'll have the talk first, and
Okay,
then we'll
right.
go ahead with the case presentation. On some days, if the discussion prolongs a lot, we may have to postpone the case presentation as well.
Okay, fine, excellent. That makes sense. So I hope you have made me a co-host. I'll be sharing the screen straight
Yes,
away.
Yes, sir. Yes, you already have that.
Hope you're able to see the screen.
Yes, sir.
Yes, sir.
All right. So as I mentioned earlier, we'll be doing the basics today. And to start off, I want to, think back on one old study way back in 1986. I like this because it is relevant. It is an all-time relevant study, whereby this was on headache. This came in the Headache Journal, and they were looking at the patient's satisfaction and what could be the best predictor for a better clinical outcome. That is, in this case, resolution of headache. And it turned out to be that the best predictor of resolution of headache, that is the clinical outcome, depends on the patient's perception that they have been listened to, that they have got an opportunity to talk about what they wanted to say to the physician in the first meeting. Now, we all know that we listen to patients, but the point is, did they feel that we listen to them? It is not about, from our point of view, whether we listened or not, but does the patient have the satisfaction that they have been listened to? And if they have that satisfaction, it has an impact on the clinical outcome of the problem. So that is why it is very important to understand that we as healthcare professionals, as doctors, when we learn about diagnostics and therapeutics, we also need to understand that despite our best diagnosis and despite our best treatment, the clinical outcome also depends on factors other than what we have been traditionally taught in medical colleges. That is how we are able to provide satisfaction to the patient, a sense that they have been listened to. A lot of medical errors also happens due to poor communication, miscommunication, inadequate communication, which are fairly preventable, but it can lead to a lot of trouble for us, especially medical practitioners. And we also need to understand that the doctor-patient relationship is multidimensional. We all know that history taking is a type of communication. We communicate with a person. And we also understand that good history taking, that means how much information, accurate information we are able to extract from the patient will lead to diagnostic accuracy. Even in this day and age where we have tests for everything, the importance of history taking has not diminished. Therefore, it is very important to understand that depending on your ability to extract maximum information, accurate information will lead to better diagnostic accuracy, and good communication skills will help you extract maximum accurate information. It also has an impact on how you're able to make the patient understand why you are suggesting what you are suggesting. I'll repeat it. Good communication skills will help you make your patient understand why you are suggesting what you are suggesting, and that will improve patient's compliance. Many times we may be writing a brilliant prescription, but the patient does not comply. So therefore, it is very important to understand what we are doing. Does the patient understand? Because the patient will comply only if the patient feels that he or she has a stake in that transaction. And if the patient complies, naturally you can expect a better clinical outcome than compared to a patient who does not comply. One second. കഥയില്ല കയ്യിലുള്ളത് ഞാനിവിടെ ക്ലാസ് എടുത്തോണ്ടിരിക്കുക നമ്മുടെ COG നമ്പറിലൊന്ന് വിളിച്ചു ചോദിക്കാം. Sorry about that. So patient's satisfaction will be there if they get good treatment. So better patient compliance means better outcome. Better outcome means patient and family satisfied. And if the patient and family is satisfied and happy with your treatment, naturally it will be a positive energy, a morale booster, not only to you, but your entire team. It also, as I mentioned earlier, has a bearing on patient safety. So good communication skills will improve patient safety. naturally mishaps, errors will come down, and your chance of getting sued will also come down. In our country, we also know that there is this instant justice where patient or the family members uh, believe in manhandling the doctor and the nurse and other medical.
Sir, I think your net connection has taken off. Your video is stuck. Sir, we lost you for the last 1 minute. Yeah, this is the slide, sir.
Okay. So basically, what I'm trying to convey is that, can you hear me? Can you hear
Yes,
me?
sir. Yes, sir. We can hear you, sir.
Right. So basically, what I'm trying to convey to all of you is that good communication skills is essential in our practice. It is not a bonus, not a cherry on the cake that we are giving to our patients and families. We have to learn communication skills for our own selfish interest because it is going to protect us. It is also going to help us save time, energy, and effort. Because that is very, very important. We don't have time to waste. We don't have energy to waste. We don't have effort to waste. So good communication skills should work for us. It should be something which improves our quality of life. Of course, it helps the patient and family and etc. etc. But it has to work for us. So we should learn communication skills for our own selfish interest. And just like foundation is the key for any building, if you have a strong foundation, you can build upon it. Similarly, for good communication skills, the concept of active listening is the foundation. Because if communication is about relationship building, active listening is the foundation, the base for it. And for today's session, we will be focusing on active listening, and that is the basics of communication. So for active listening, I have divided this concept into two. One would be body language, and the second would be the verbal language. And why should we learn body language? Because most of the time, when we are communicating, we are not very aware of our facial expression, our eye contact, the tone of our voice. What is my hands doing when I'm talking to you? Which way my body is facing? Where are my toes pointed? Whether I'm sitting, leaning, whatever. So all of these things convey some messages. And most of the time, we are not actively aware of that. We are focusing on what we are saying, not necessarily of how we are conveying. And it is very important because we don't want to send mixed messages. One, what we are verbalizing, and second, what our body is conveying. Another important reason why we should learn body language is because across cultures, across language, across regions, the major component of any communication is body language, non-verbal. And the share of non-verbal can range anywhere from 100% to lesser than that. But by and large, it is understood that it has to be around 70% or more. So if you can master good body language, then a major chunk of that is taken care of. Of course, you can't learn everything about body language, even if you spend a whole lifetime on it. But if you're interested, you can Google and search for positive body language for doctors or positive body language for nurses. And there's a lot of material available which you can use. But for today's session, I'm just going to restrict myself to around 6-7 points. And Let us start with that. First and foremost, if you are uh, interacting with a human being, the starting point is always making an eye contact, because eye contact is the starting point for any relationship, personal relationship, social relationship, professional relationship. As doctors and nurses, when a patient comes to you, if you're focusing on the computer screen and just sit, that gives a very poor impression. Or if you're focusing on the file, when you're going to see a patient in the IP and you enter the room looking into the file, that creates a very bad impression, because it is not satisfying when somebody comes to talk to you without making eye contact with you. So as healthcare professionals, we have to make sure that when somebody comes into our room or we go to somebody's room, then make sure you start with an eye contact. Along with eye contact, there is something universal about smile. Whichever culture you go, whichever region you go, smile means it is welcome. It is non-threatening interaction, a very, very positive interaction. Now, we human beings are designed to smile instinctively at somebody we know, at somebody we like, love, but we are not designed to instinctively smile at somebody we don't know. Therefore, it is important to practice what we call professional smile. There are many professions which deals with interaction with other human beings, which practice professional smiles. For example, in the airline industry, you have air hostesses welcoming the passengers with a smile. Good morning, sir, this way. You have people in the hospitality industry who welcome you. The security guard welcomes you with a smile. People at the reception of the hotel or the resort welcome you with a smile. At every point, the, the human resources of that particular area smiles at you, except maybe in the healthcare system where people need it the most, because people don't come to us because they have come for a picnic. They come to us because they are sick, they are ill, they are suffering. All the more reason for them to get a smile. But in the healthcare area, doctors, nurses not often smile at patients and their family members. So this is something that we have to train ourselves. It is a skill, just like you check BP, blood pressure. Remember our first physiology lab session where they taught us how to tie the cuff on the arm, how difficult it was to position it correctly with the tubings correctly on the cubital fossa. Sometimes it would slip, sometimes it will be too tight, sometimes the tubes will not be in position. But somebody taught us and we practiced it. And with practice, we became, very proficient in taking BP. Now we don't have to think about it. We can take a BP like a spinal reflex without really thinking about it. Similarly, you have to practice professional smile. So you practice it so much so that it becomes a spinal reflex. Anything resembling a human face, it passes in front of you, a smile comes on your face. So where can you practice? A safe place for you to practice is in your own hospital. Start practicing smiling at the security guard, at the ward boys, the cleaning ladies, the catering staff, the administrative staff, your colleagues, people whom you don't usually see. Your physiotherapist, the pharmacist, the nurses, your doctors, anybody. Consciously practice this, and then eventually it becomes a second habit. You don't have to think about it, but it will come only if you practice, because professional smile does not come because it is not instinctive smile. It is a learned skill. It comes only if you practice it. Now, if you practice it I have got good news for you. Like when you go to a mall or a shop, and if you buy one, you get one free, most of us feel happy about it. So if you promise to practice professional smile, I guarantee you a good tone of voice, free, completely free. Because with a smiling face, you cannot have a bad tone of voice. Just try it. With a grumpy face, come, sit. With a smiling face, come, sit. The same things, the tone will be very different. So with a grumpy face, you get a grumpy voice. With a smiling face, you get a smiling voice. What do I mean by that? Even if you cover your face with a mask, your smile can be seen in your eyes. Even if you cover your eyes, your smile can be heard in your voice. Your voice will be nice, warm, welcoming. And remember, many a times, a lot of friction, lot of fights start not because of what you said. It starts because of how you said. So the good tone of voice is an insurance against friction. So what you say is usually not the source of problem, but how you say can be the source of friction. So a smiling face gives you a smiling voice, and that will protect you from almost or most of the problems, right? So even if somebody is angry and you welcome that person, the person's anger will dissolve with your smiling face and your smiling voice. Now let us focus on body positions. Now, this is an important slide and I would like to spend some time here. You see this healthcare professional standing by the bedside of this patient and they are making eye contact, right? And look at the neck muscle, the sternocleidomastoid of this person. It is looking very taut because if somebody is standing near to the head end, the person has to turn the head at an acute angle to make eye contact. So it can be uncomfortable. Instead of that, if this healthcare professional was standing near to the foot end of the patient, this patient could have made eye contact much more comfortably. So when you enter a patient's room in the IP, first position yourself near to the foot end. This is the time when you say, hello, how are you? How are things? That kind of things that you can ask without having to go near to the head end of the patient. Subsequently, if you want to examine the patient, etc., you go near to the head end of the patient at that point of time. But otherwise, it is always good to position yourself near the foot end of the patient. Now, here is another example. Here you have a healthcare professional sitting near the foot end of the patient. You can see this patient is able to make eye contact much more comfortably without having to turn the head in an acute angle and becoming uncomfortable, right? Another difference is when you sit, your eye contact is more at level than compared to this. Now here, I would like to emphasize one more point. When patient and family come to us into the healthcare world, into the healthcare area, they are seekers of our services and we are providers of this service. So this and this are never equal. Irrespective of they may be very wealthy, they may be very poor, they may be socially very high, socially very down, doesn't matter. When they're sick, they come to the healthcare area, they are in this position. They are seekers of our help. So it doesn't matter whether you're a doctor or a nurse or a physiotherapist or a ward boy or a cleaning lady, it doesn't matter. We are all in this position and they are in this position. In the outside world, we may be different, we may be much lower than them, but inside the healthcare system, we healthcare people, everybody is in a provider position, and this is never equal. It is never equal. There is always a difference. But if the difference increases, satisfaction decreases. If the difference comes down, satisfaction improves. Therefore, if you stand and talk, the eye contact will not be level. There will be a hierarchy of eye contact. The healthcare provider is in a higher position, the patient is in a lower position. Whereas if you sit down, that hierarchy is reduced. It becomes more equal. It is never equal, but it becomes more equal. Therefore, standing and talking compared to sitting and talking will be more satisfactory for the patient and family. You will be spending the same time. Let's say when you go for your IP round, let us say you spend 3 minutes in your patient's room. But that 3 minutes, if you spend standing and talking, compared to sitting and talking, the same time, you will give more satisfaction if you sat down and talked. So when you enter somebody's room, position yourself near the foot end and preferably sit down and talk, how are you, how are things, etc., etc. And then you want to examine, then you come forward and do the examination. Second important thing is when we are dealing with children, because children are smaller in size compared to adults, we adults have a tendency to bend at our hip and look down on children. So it is a top-down approach, and that can sometimes be scary to the child. The children tend to get scared. Whereas if you position yourself, you get down on your knee or pull up a chair or a stool and sit down and talk to the child eye to eye level, there is much more likelihood that the child will not be scared of you. Therefore, it is important that to win the trust of children, you position yourself, you, like my teacher, Dr. Rajagopal sir, countlessly have demonstrated n number of times whenever there is a child to be, taken care of. You go near the child, humbly introduce yourself. Say, my name is so and so. Sir would say, Ende pere Rajagopal. My name is Rajagopal. Then he would ask the child, may I sit here? And the child will look and, will feel a little embarrassed and, that this adult is asking me. The children don't have the vocabulary of the adults, but they show with their body language that, yes. So they may look at you and then they may bite their hands and they smile and things like that. Then you sit down. And when you sit down and then you have a eye level contact, then children lose fear of you as a doctor or a nurse. And that is one excellent way of gaining their trust. And as far as adults are concerned, this is an excellent way of gaining their respect as well as trust and also satisfaction. Now coming to another aspect. Earlier we were talking about body position. Now we are talking about body posture. Look at this group. Look at these two pictures. On this side, you have a gentleman in lordosis. Now you don't have to have an exaggerated lordosis, but when you sit and if your back is touching your chair, rest assured you are in lordosis. And look at this lady over here. Now this is the way we sit in front of our examiner whenever we are having our university viva. This is a slight kyphosis. We are sitting in a slight kyphosis. And this body posture is conveying, I am here to listen to you. And lordosis is conveying, I am not interested in you. So whenever a patient party comes to you, start with some kyphosis. If it's a small interview, no confusion. You start and end with kyphosis. However, if you're dealing with complicated counseling sessions, which may extend for some period of time, in that situation, you always start with slight bending, leaning forward, which is kyphosis. And you'll also notice that the patient party always comes and sits and leans forward. Nobody comes and sits and starts with lordosis. The patient party always comes and sits in front of you and leans forward in kyphosis. You also start with kyphosis. But if it is after maybe 5 minutes or between 5 to 10 minutes of the discussion, I'm talking about complicated counseling sessions when we are dealing with very advanced medical condition or complicated medical condition, or talking about terminal illness, those kind of things, not your day-to-day cough and cold and things like that. I'm not talking about the mundane daily things. I'm talking about daily, not the daily things, but the complicated counseling session, which may extend for some time. So after the initial 5-10 minutes, the patient party may lean back a little bit. In that case, you also lean back. And sometimes after some time, they may lean forward. You also lean forward. This is called mirroring. It's like when you're standing in front of the mirror, when you go near the mirror, the image comes towards you. When you go away from the mirror, the image goes away from you. So it is like a dance. So you start with both parties in kyphosis. And after some time, the patient party leans back, you lean back. Then after some time, the patient party leans forward, you lean forward. If they lean back, you lean back. Basically, you follow their gesture without them actually noticing that you are doing it. Now, the psychology behind that is when you copy somebody's gesture, you make yourself likable to the other person. That is, if the person does not realize it, it's a psychological thing. If it appears to the person that you are copying the gestures, they may not like you. So it has to be very subtle, right? It has to be very casual. They should not know. But when you do it at a psychological level, you make yourself like him. And that is the whole point. We are building up relationship and increasing satisfaction for the patient and party. That means interaction with you should be satisfactory to them. That is our success. So these are some examples of how you deal with patient party as a healthcare professional. Another area of importance is respecting body space. We commonly have an intimate space, a social space, and a public space. Intimate space is where we interact, we allow people with whom we are intimate to come into that space. It starts from our own body and up to about a feet or two, about 1 or 2 feet. And within that distance, very close to us, we allow only those people with whom we are intimate. Beyond that is the social space, up to about a meter distance, where we interact with people we meet on a daily basis, like our colleagues, but who are not intimate to us. Then there is the public space, where we keep a distance from strangers or people we are not very sure of what their intentions are. So we keep a little bit more distance. This comes naturally to us. However, in the healthcare profession, our patients who are nobody of ours, they come to us with their illness, sickness, whatever. And because of our profession, we have to intrude into their intimate space. We have to auscultate them, we have to palpate them, percuss them, etc., etc. We have to put in a cannula, we have to check BP. In all cases, we have to intrude into somebody's intimate space. This can be uncomfortable. Not can be, it is often uncomfortable, because it is not something that you willingly allow yourself to allow some stranger to come into very personal space. Now you can say there is an implied consent. Of course, there is an implied consent. They came to you because they wanted to. There is an implied consent. What I'm saying is, despite the implied consent, emotionally there is discomfort. Therefore, to minimize the emotional discomfort, we have to do something. And that something is telling them what you're going to do before you actually intrude into their intimate space. For example, I have a step, and if I'm going to examine a patient, I'll put the earpiece in my ear and I will show them the chest piece and just tell them, or I'm going to examine you, something like that. A gesture or a word, something which helps, which makes them understand that I am going to touch them. That is enough, because that will help them mentally prepare for this thing. So without telling them, if you suddenly go, sometimes they feel so uncomfortable that some people may actually recoil a little back. Even if they did not recoil back, it is always a good practice to tell people what you're going to do before you actually touch them. When it comes to procedures, for which they are not going to undergo general anesthesia, so if they are away, minor procedure to major procedure, whatever it is, you tell them about the procedure in very brief, which most people do. For example, if I'm going to put in a urinary catheter, I'll tell them I'm going to put in a urinary catheter, but that is not enough. While you're doing the procedure, do a running commentary of what you're doing. I'm going to clean that area. I'm going to clean your urine area with a betadine solution. It will feel a little wet. So I'm cleaning it now. Okay, I'm done. I'm going to put a cloth over that area. Now don't bring your hand into that area. Keep your hand under your head and relax. Okay. Now I'm going to push a little bit of a jelly into your urine area. This may feel a little weird, little uncomfortable, but it's not going to be painful. And just injecting this jelly. Okay, now I'm done. I'm just going to wait for some time. Meanwhile, I'll arrange the tubes and things that I'm going to use. So so I'll just you just lie there for around half for about a minute or two. Then you can get things in order while you wait for the cane to act or whatever. And then, okay, now I'm going to insert the tube, right? So in case you're feeling any pain or any discomfort, just let me know. Otherwise, I'm sure this is going to be very, very comfortable. Then you start putting it. Then okay, the tube, I have put the tube in, and just make sure it is in position. Okay, now I had checked it's in position. Okay, right. So I'm just going to clean you up, and then I'm going to remove this cloth. Okay, I'm just going to clean this area. Okay, we are done, right? So this way, if you give a running commentary, so that patient is lying and knows exactly what is going on. Otherwise, sometimes you see people just trying to lift their head up and trying to see what is going on. And if we are not saying anything, sometimes they get very anxious as to what is going to happen, what is going to happen, what is going to do, who is going to do what. And sometimes when we touch them, suddenly they get jerked up because they are always anxious as to what is happening. So just like when you watch cricket, you want to watch it with running commentary. Similarly, when you do a procedure for your patient's comfort, give a running commentary of what you're doing. It's not ball by ball running commentary, but at least tell them what every step of the way what you're doing. This will reduce their anxiety about you intruding into their personal space. So even though there is implied consent, by these methods, you will help them cope up with the discomfort. And this is in a sense respecting body space. Another example I can give you now, as adults, most of us, we love children. And as a result, when we see children, we want to pinch their cheek, we want to ruffle their hair, we want to pick them up. And most of the time, children absolutely hate it. But as adults, we do it because we love children. And society sanctions us violating a child. Underline, violating a child. Because society understands that as adults, we are doing it out of love for the children. But please understand, it is not enough to love children. It is also important to respect children. And respect children means respecting their body space. Even with the best of intention, you should not violate a child's personal space, a child's intimate space. You build up a relationship And then the child would want you to pick him or her up, the child will climb all over you. But once build up that relationship, without that, when you do it, you're basically harming the child, you're traumatizing the child, you're making the child uncomfortable, and we should not do it. We should love children as well as respect children. So here are two examples of this discomfort. Here is one example where you can see a healthcare professional intruding into the personal space, and look at the body language of this person, trying to lean back as much as possible into the chair, and look at the facial expression, right? So this professional may not mean any harm, and but just the way this person does not realize that his body language is causing discomfort here. And there is a totally different picture on your right. This is my palliative nurse on home care with my patient. This is pre-COVID. Now look at this picture. Everything that we talked about till now is there. Eye contact, smile on the face, right? And I'm sure the tone of voice will also be good. You can't have bad tone of voice with this kind of smile. Then look at the body position. Both are sitting. And look at the body posture, leaning forward, a slight kyphosis, you can see, leaning towards each other, right? And look at the comfortable distance between both parties, very comfortable with each other, right? So this is what we should be. So this image itself, this picture is conveying something of how comfortable a healthcare professional and the patient can be with each other, right? And last but not the least is the human touch. There is nothing more powerful than a human touch. It's the most powerful therapeutic tool known to human beings. But that does not mean we should go around touching people at random. So there has to be a context. So when we touch somebody, a patient or a family member who is distressed in our clinical environment, that is perfectly all right. But you see that person 2 weeks later at the bus stop, don't go and touch that person because 2 weeks ago you touched that person, because in the first instance it was in context. At the bus stop it is out of context, so it has to be appropriate. Then there has to be gender neutral places where you can touch, for example, the palm of the hand as in a handshake, the back of the hand, the forearm, the arm, and the shoulder. And then there is a method of touching. If you pat somebody, it is paternalistic. You can pat somebody only hierarchically lower down to you. You cannot pat somebody hierarchically above you. Can you go and pat your HOD and say, good madam, good sir, we are very happy for you? You can't do it. You can only pat down. So therefore, I will not recommend patting. The best touch is what it says, touch. Just touch somebody and then take your hands off. Don't leave it there for a long time. So that is most appropriate. And please do it. When I extend my hand to my patients who come into my OP, when they are leaving, I give them my hand. Or when I've gone to see patients in IP and I'm about to come out, I give my hand. You can see the happiness in the patient's face. Most of these patients, especially the elderly, they grab with both their hands to my extended hand, and it really builds up great relationships. It increases patient satisfaction, family satisfaction. So anything and everything, that just 7 points that we talked about, today, everything is going to enhance satisfaction, and nothing is going to cost you time. Eye contact does not cost you time. Smile does not cost you time. A good tone of voice will not cost you time. Sitting and talking will not cost you time. Sitting with a slight leaning forward will not cost you time. Respecting body space, being respectful in general does not cost you time. A human touch does not cost you time. You spend the same time that you spend with patients in OP or IP or home care. whatever time that is, but you practice this, you will enhance their experience of you, and you will also feel a lot of positive energy. So I'm stopping there. I mean, I can go on and on and on about body language, but somewhere we have to stop. So I'm stopping at that point. Now we'll come to the verbal do's and don'ts. Your pain is better now, isn't it? When you ask a question like that, the patient sitting in front of you may be too scared to say, no, I have no relief. So never ask a leading question, because remember I told you that information is power, and the good communication skills gets you information, but information is useless if it is inaccurate. So the purpose of communication skills is to get maximum accurate information. Maximum accurate information will give you the power to decide what to do and what not to do. So leading question can give you wrong answers. It may give you right answers, but there's a chance that the person may feel not empowered enough to tell you the truth. Therefore, ask an open question. How are you today? And they will tell you. So just a matter of how you frame a question that can get you a wrong answer or a right answer. An open-ended question will always get you the right answer, and it will also give you more information. Not only will they tell you about the pain, because you did not ask how is your pain today, you ask how are you today. So they will tell you about the pain. They'll tell you that I did not pass motion today. They'll tell you I could not sleep because there was a lot of noise in the next room and therefore I could not sleep. So they'll be able to tell you a lot more, and you will get a lot more information than when you ask something in a leading way. Second, if I have a toothache, and if you say, oh, it is nothing, don't worry, it is such a small thing, I'll hate you for it. Because for me, my toothache is the biggest problem for me right now. So do not minimize my problem, my suffering. And if you tell what is your toothache, you go to the children's cancer ward and see, you will see real suffering over there. With my toothache, I don't care whether children in cancer ward are suffering, because for me, my toothache is the biggest problem in the world. For me, my toothache is the only problem in the world. So you will reduce my satisfaction of my interaction with you if you minimize my problem or compare my problem with something else. You may be doing it for best intention. You may be trying to protect me. You may be trying to help me, but it does not help me. It only gives me dissatisfaction. Instead of that, if you say, oh, you're having toothache, this must be terrible. How are you feeling? And I say, oh my God, I can't go to work, I can't sleep, I can't do this. And so that means you are acknowledging my problem. And then I'm explaining, I can't sleep, I can't work, I can't eat, and all of that, I'm making a big fuss. And if you say, my God, anybody in your position would be in this position, there you are normalizing my emotional experience of that problem. I would love you for it, because I feel that here is one person who understands my problem. Here is one person who is empathetic to my problem. Therefore, never minimize, never compare somebody's problem. Always acknowledge their problems and normalize their emotional experience of that problem. You are not normalizing their problem, you are normalizing the emotional experience which the problem is bringing to that patient. Never give false hope. A lot of time our patient and family members go through a lot of problems when you do not tell them the truth. And it is always possible to tell the truth in a very, very humane way, in a very sensitive way. But if you don't tell the truth, you cause people a lot of problem. And we'll come to that at another session for the next day, when we'll talk about communicating bad news, or in short, truth telling. Why it is important not to give false hopes, because oftentimes we as healthcare professionals give false hopes because we just don't know how to tell the truth. Nobody taught us that, and because we don't know how to do it, we feel very uncomfortable doing it. In my day-to-day practice, I always give realistic hope. And even today, I mean, there was this occasion where a patient and family came to me and was sent to me from the pulmonologist for an advanced COPD, refractory breathlessness. They tried everything, basically, bronchodilators, steroids, uh, oxygen, NIV, everything, antibiotics, multiple times. So basically, the point is, irrespective of the area you work in, you can be neurologist, cardiologist, pulmonologist, nephrologist, gastroenterologist, oncologist, doesn't matter. There are limits to cure, but there are no limits to care. So I tell patients that irrespective of the fact that your disease is no longer curable, I'll make sure that you do not suffer. So your disease is incurable, it is progressive, but I'll make sure that you do not suffer, and you can come to me any number of times. Now, if you're wondering what is the response I get, the responses I get is, doctor, that is all that we wanted to hear. Sometimes the response is, doctor, now I feel courage. Now I feel encouraged. Now I am not scared. So this is the kind of response that I often get when I tell the truth. I tell them that the disease is incurable. I tell them it is progressive. That is the reason your disease treating doctor referred to me. But I also give them realistic hope. See, palliative medicine it really improves, your ability. You never have to say nothing more from my side. That is the strength that palliative medicine gives you. You never have to say to any patient, irrespective of diagnosis or stage of disease, that there is nothing more from my side. Another thing that you may want to consider is, none of us, nobody, not we, nor our patients, nobody wants to get sick, right? You sitting there, me sitting here, our patients all from all over the world, nobody wants to get sick. But the fact is, we all get sick. But when we get sick, then we hope to get cured. But if we have an illness, a diagnosed disease, which is incurable, then we would hope that we will not suffer. That is a realistic hope we can give, that we'll make sure that you do not suffer. Another thing that people who suffer hope is that they will never be abandoned by the healthcare professionals. And that is also a guarantee that we as palliative care professionals can give, that no matter what is the stage of disease, whether it is curable, chronic, incurable, advanced, terminal, no matter, we will be there for you. That is realistic hope. And we give it on a daily basis. So it is not something that it is not something that is hard. It is not something that only few people can give. If you learn how to communicate, then if you learn how to make sure that people remain comfortable, it is easily doable. So never give false hope, always give realistic hope. Never assume, never ever assume. How is your breathlessness? Much better. Do you have satisfactory relief? Not really. So this is something that each one of us need to practice. Asking, do you have satisfactory relief? If no, that means we need to do more. I'll tell you another story. That was about when I was doing my post-graduation. There was this patient who had initially come to gastroenterology with jaundice. And they found that this patient had a fairly advanced stage chronic liver disease. On top of that, they also found that this patient had hepatocellular carcinoma. And they referred this patient to the medical oncologist, and the medical oncologist had an evaluation, and they found that the hepatocellular carcinoma was also fairly advanced. And because the chronic liver disease was also advanced, they really had nothing to offer to the patient. And then they referred to palliative medicine. And since I was the PG, I had gone to see this patient. And when I went into the 4-bed cubicle, the bed was empty. The patient was not there. I went and asked the nursing station I asked the nurse, where is this patient? And the nurse said, oh, he usually sits at the end of the corridor watching TV. So most probably is there. I'll go and call him. So the nurse went and called the patient from the TV, the common TV viewing area. And I saw him walking towards me. And as he came near me, he gave me a broad smile. And then I also smiled at him, and together we went into the 4-bed cubicle. He sat down on his bed. I introduced myself. I said, I'm Dr. Biju. I came to see you. And just with this introduction, he said, Doctor, I know everything. My problem is in my liver, and my condition is this. This was non-verbal, and my condition is this. So, usually when offline classes happen, I ask people, what do you think? What are your comments on it? So many people say, yeah, I mean, this person is very brave. Some people say he has come to accept that he is going to die. And when I asked them to elaborate, they said that, he understands that he's got an advanced cancer. He has no treatment. He understands that, and he has come to terms with it. Some people say that he's only hiding his emotion. That smile is not a real smile. It's a fake smile. He's just trying to be brave, and he's actually depressed. So I get all kinds of feedback like that. And I don't know whether you are also having the same thoughts in your head. But then I asked him, why did you say that? Remove the sequence. He was coming towards me. I was standing at the nursing station. He smiled. I smiled. Together, we walked into the 4-bed cubicle. He sat down on his bed. I introduced myself. I'm Dr. Biju Raghavan. I came to see you. And he said, Doctor, I know everything. The problem is in my liver. My condition is this. At this point, I asked him, why did you say that? I said in Malayalam, and he said, Doctor, in my good days, I used to drink a lot. And because of that, now I have pus in my liver. So this gentleman had no idea that he had a chronic liver disease. He had no idea he had hepatocellular carcinoma. He had no idea that he had an incurable advanced medical condition and he was not going to live long. He had no idea. And the point is, we should not assume based on what people say. We have to ask. Asking is the simplest thing, and you will get an answer. But most of the time, we do not ask, we assume. That is why it is very important to do not assume, because when you assume, you make an ass of you and me. ASSUME. So once we are done with that, let us revisit our history taking. I know all of you know how to take history, but little bit of what we talked about regarding active listening skills, body language, as well as the verbal do's and don'ts. Let us revisit history taking. That is why I call it history taking 2.0. So first and foremost, greeting. Whichever region you are in, whatever language you speak, first and foremost, when a patient comes to you in the OP or you go to a patient's room in IP, first there should be a greeting. Greeting consists of eye contact, a smile, and what is culturally appropriate in your area. If not saying anything is okay, that is also fine. But greeting. Then the next important thing is get comfortable. If patient comes to you, give them a chair. Patient family, give them a chair to sit down. If you have gone to see a patient, you pick up a chair or pull up a stool and sit down, make yourself comfortable. Because it is even if you're going to stay there for 2 minutes, sit down. Then start the interview with an open-ended question. If a patient has come to you, you say, okay, what brings you here? How are you? How can I help you? Or tell me, whatever, depending on what you want to say. But it should be open-ended question. If you have gone to see a patient and you already know this patient and this is not the first visit, you tell them, how are you today? So it has to be an open-ended question. And once you have started with an open-ended question, then you listen. Do not interrupt, because there are plenty of studies, real research studies, which have shown that doctors interrupt their patient within the first 15 seconds of the patient opening their mouth. We are very, very impatient people. So it's very important to remember that the patient has to speak without we interrupting. Keep that in mind. And not only we should not interrupt, we should encourage the patient to talk. How do you encourage? 3 points. Maintain eye contact, because eye contact is what keeps the relationship going. The most important, the first point is always eye contact. Starting point, maintaining point is eye contact. Along with it, nod your head from time to time, because you are conveying that you are following the conversation, you are understanding this conversation. And also make encouraging sounds. Okay, okay, go on. So these kind of encouraging sounds, if you just sit and stare and not nod your head or not make any sound, after a few sentences the patient will feel confused. Should I continue? The patient may feel scared. Should I continue? So it is very important to encourage the patient to talk by your body language. Irrespective of what, it is very important for you to have clarity on what is being conveyed. So if you did not understand a word, if you did not understand a sentence, if you did not understand the message, you clarify as you go along. What was the word you said? Can you just repeat it? I did not hear. What was this you said? Can you just say that once again? Or are you trying to say that this is what happened, so and so? So these are many ways of clarifying as you go along. Don't wait, don't say that, okay, I will talk about this later. I'll keep this in my mind, I'll talk about later, because you never know where this conversation will go. It's always important to clarify as you go along, even if it's a short 5 minutes interview or a half an hour, 45 minutes long, complicated interview. Another important thing that most of us do not explore is, what does the patient understand about his or her medical condition? What is it what is their insight? What do they understand? For that, simple questions like, what did the doctor there tell you? What did they tell you after seeing the reports? What is it that you have been told? And often you'll be surprised, many times they have no idea. Many times the patient I see, I think it must be universal. Many times the patient I see, they don't even know the name of the doctor or even the specialty of the doctor that they saw in some other place that they had been to, and they come to me. So it is very important that first of all, market yourself. If you don't market yourself, who will market yourself? I go around telling people my name. I'm Dr. Biju. I'm so and so. As long as it is there on my door, but I also tell them when I go see patients. I tell them, and even if at the next visit I tell them, and if they say, "Oh, doctor, of course I know you. I remember." I said, "I was just telling you in case you forget. I don't want you to forget me." So this kind of also builds up relationship. Remember, relationship will protect you from litigation and physical harm. So it is in our own best interest, in our own selfish interest, to keep building up this kind of relationship. So ask about what they understand. Also, it is very important to understand what their concerns are. See, people have beliefs. For example, some people believe that if you take radiation, you will die. As medical professionals, we know it is not true, but people believe that. Some people say that, the death happened in the hospital because the nurse gave the wrong injection. It is their belief, right? So for people, what they believe is real to them. So therefore, it is very important to understand that people have beliefs, they have concerns, they have fears, they have financial concerns, they may have logistical concerns. If you are saying, okay, this patient needs admission, but then the problem from the patient end is that there is nobody to come and stay with the patient, or somebody has to forego one day of or the number of days of admission, the person has to forego going for work, and this will lead to income problem, etc., etc. We don't know, we don't understand the lives of our patients. We may understand the medical part, but we don't know major part of their lives. Therefore, it is important to ask about these things, and you will get information. And information gives you power, because then you can take decisions which are more practical, which are more doable, and only practical decisions will get you good clinical outcomes. You can have the greatest of knowledge, you can write the best prescription, but if the patient is not able to afford it, you're not going to get a clinical outcome. You will get a clinical outcome if you understand that they have financial issues and you write the most affordable prescription that the patient can afford, then you will get a clinical outcome. Otherwise, you will not get a clinical outcome. So it is very important that we understand their side of the socio-economic concerns and beliefs, etc. When it comes to sharing information, share it honestly and in a simple language, right? So most of you if I wake you up in the middle of the night and ask you, what is the name of this bone over here? Right? So do you know what the name of this bone is over here? Dr. Deepak? Dr. Deepak? What's the name of this bone?
Clavicle, sir.
Yeah, if I wake you up in the middle of the night when you're deep, fast asleep, and I ask you the name, you will say, what?
Clavicle.
Clavicle. But you will never say collarbone.
Yeah.
Thank you for that. The reason is because medical education is drilled into our head in foreign language. Clavicle, the word clavicle comes from clavus. Clavus is Greek, which old Greek, which denotes key, like a key. Clavus, key. And clavicle came from clavus. Clavus is Greek, clavicle is Rome, is the Latin, the Roman version of the clavus, which is, so Greek becomes Latin, clavus becomes clavicle. And most of our medical education is Greek and Latin. It is not English. English is collarbone, right? So dorsum, plantar, all of these words that we're speaking, they are Greek and Latin. And we learned it because we did not know. And most of us, we are very proficient in Greek and Latin because that is a language we speak on a daily basis as doctors and nurses. But when people sitting in front of you, they hear you talk, it sounds like Greek and Latin to them because it is Greek and Latin. And therefore, it does not make any sense to them. You can spend half an hour counseling them. They will sit and shake their head. But at the end of half an hour, they'll say, we did not understand anything. And it is not your fault. It's not their fault. And honestly, each one of us used to speak normal human language that our, whichever geographical area we are in, was speaking. But before becoming doctors and nurses, we were speaking normal language. After becoming doctors and nurses, we are speaking Greek and Latin. And we don't even realize it because nobody told us that this is this language. And therefore, from our point of view, we are talking absolutely sensible things. We are taking great pains and efforts to convey the message, but somehow the people don't understand. It is because what we call jargon does not seem jargon to us because we know this language. If I speak in Japanese or Korean or Chinese, it will not make any sense to you, right? Same thing. So we have to unlearn, and that is what it means, no jargon. That means we have to unlearn Greek and Latin and speak to people in a language they understand. For example, if I say, if I tell you the USG abdomen showed a cyst in the liver, sorry, a cyst in the ovary, nothing to worry about. Each one of us here will understand what I'm talking about. But if I tell this to a patient, a non-medical person, they will, for example, if I'm telling this to a patient, they will say, USG abdomen, I paid money for scan of the tummy. So they did the wrong test. I paid money for scan of the stomach and they did some wrong test called USG abdomen. So therein the communication problem started. And then ovary, I understand. Cyst means cancer. I know cyst is cancer. and they are saying there is nothing to be worried about. So instead of causing so much of trouble by using jargon, USG abdomen, cyst in the ovary, if I had simply said that your scan of your stomach has come, there seems to be some swelling over your ovary, which does not seem to be much of a problematic thing. We can just wait and watch. It will convey the same thing, but in a language minus the jargon. So that is what I meant by sharing information honestly, but it is of no value if you don't use language which conveys the idea to the other person, right? And it's also important, the next point is discuss treatment option. Don't suddenly become a bearer of a hotel. You know, what is there to eat? I got this so items and you choose. No, as a healthcare professional, as a doctor, it is your job to guide them, to help them reach a decision in their best interest. You have to take the role of a friend, guide, and a philosopher. That is the traditional role of a doctor, not a bearer in a hotel just tells you the menu item, that what are the things and how much it costs. No, you have a much bigger responsibility. You cannot be a prescription vending machine. You cannot be a what you call procedure doing robot. You cannot be a bearer in a hotel. So you have to discuss treatment option. That is again where the empathy part comes in. If this was me, what would I have decided? If this lady is like my mother, if my mother was in that situation, what would I have had done? So that is very important in to consider when we guide them on what should be done, should not be done. Also factor in their beliefs, fears, which I talked about later. Another important thing is participatory decision making. We are all familiar with participatory decision making in the medical system, whereby we practice participatory decision making in tumor board or medical board, or just cross consultation between different specialties. We take opinion from other people on areas that we are not very familiar with. So if we are able to do that within our medical system, what stops us taking doing a participatory decision making with the patient and family? First, get a medical opinion as to what are the best options for a patient. Then discuss this with the patient and family. Talk to them. Then they will tell them the practical things. For example, you are telling this is the best option, but if the patient can't afford it, or there are logistical problems, then you have to go for the next best possible. Because ultimately what gets done is not necessarily the best option. What gets done is the most practical option. And the most practical option gets done, it will get you outcomes, clinical outcomes. So that is why it is important to do a participatory decision making, because it gets you to a point where you can reach practical decisions. Also, since everybody has participated in it, in case it fails, only the doctor will not be blamed for that. Therefore, it is also safe for us if we take patient and family also into consideration when we take a decision. Gone are the days of the mighty high and mighty doctor who says my way or the highway. Now it is much more of a democratic situation. So the last part is you confirm the treatment, you close the interview. The last thing that I do is, after all the discussion, last I ask question, is there anything else you want to ask? Now that gives the effect of a sweet dish, a dessert at the end of a meal. You have a good meal, but it feels complete if you take something sweet at the end. So dessert in all cultures is usually at the end of the meal because you feel complete. So when you ask this question after all the discussion, after 5-minute discussion, half an hour discussion, 45-minute discussion, doesn't matter. Simple discussion, complicated discussion, at the end of the discussion, always ask, is there anything else you want to ask? It brings a smile to the patient and family's face. So whether they are going from your OP or whether you are coming out of their IP room, it should be with a smile on their face. And this last question, is there anything else that you want to ask? Brings a smile. It brings a completion to the discussion. And leaving the door open, that is basically, even if you don't want to give your personal mobile number, don't give, but give them some number through which they can ask contact for help in case they find themselves in some problem before the planned visit, next follow-up visit. Let's say you have told them that at discharge, come after 1 month or come after 2 weeks. After OP, you have told them you come after 2 weeks. Suppose they find themselves in some problem after 1 week. Then what do they do? Many times people don't know what to do. They think that you cannot go back to the doctor. I personally come across many patients and families who say that, but the doctor told me to come after 2 weeks. How can I go before? It seems like common sense to us, but please understand the patient and family don't know. So I personally tell them, come after 2 weeks, but come early if you want to. And I give them a number. So it is your personal choice. You can give your personal number, or you can give your department number, whatever, some number that they contact, the casualty number if there is an emergency, whatever, but give them some number. So that is what I mean by not shutting the door completely, but leaving the door little open. And finish by, again, how you started, by greeting, make eye contact, smile, and say what is culturally appropriate over there, right? So this kind of brings this to completion. And to summarize, everything that we talked about today is about enhancing the patient's experience of us. You may be working in a 5-star hospital, you may be having many degrees, you may be having equipments worth crores of rupees, but your patient and family may not remember any of that. What they remember is how they were made to feel. And how they were made to feel is our responsibility. And how we behave physically and verbally, that is where the empathy comes in. Sympathy you can do. You can say a word, oh, sorry, this was so sad, etc. Sympathy, and everybody, people hate people showing sympathy. I wouldn't want anybody to show sympathy to me. But empathy is not something that you do. Empathy is that you live through your behavior, right? Through your gestures, through the choice of words you use. So everything that we talked about, active listening skills, is how you practice empathy. And that is what enhances their experience of you. That is what enhances relationships, that satisfaction that comes out of it. And it will enhance your life experiences as well. Because the more good relationships you build with your patient and family, it elevates you. It makes you feel good, right? You develop a lot of positive energy within you. So sum it up, I'm already overshot. Practice positive language, positive body language, and make sure of how you're using your words. Do the do's and don'ts. Thank you. As I said, I've already overshot. We can have questions, or we can go to the case discussion, and we'll take it from there. I hand the baton back to the host, Dr. Deepak. And
Thank you so much, sir. Amazing session as always. I have already informed Dr. Kasturi, who was supposed to present today, that our due apologies, because we'll be short on time today. But in the interest of discussion and interaction with you, we would take up the discussion and have the case presentation later on. She has already responded saying the session is fascinating and extremely interesting. So there you go with your first what's it called? Compliment for the evening.
Compliments are very important. It elevates you. And I suggest that we make a practice of complimenting at least one person every day. It elevates their day. It also creates positive energy within you. So thank you for that compliment.
So we already have a lot of questions
Yes,
on the
please.
chat box. One of the major questions which has come up is in this digital world which we are living in, where we depend so much on technology. We are trying to transition to depending on telehealth or many modes of communication is happening online these days. So, and there, there are a lot of apps also. Practo, even the government has got an online consultation facility now. So, in these circumstances where we are so heavily reliant on digital infrastructure, how can we communicate as effectively as you explained to us till now?
Oh, we use technology. Absolutely. We embrace technology. Because human beings need to interact, and the best interaction is face to face, offline, but online is also good. During before COVID, telemedicine was there, but most of us were skeptical, including me. But when COVID showed that we can do business just as usual online, and since COVID started, I've almost stopped visiting Parliament and Trivandrum and doing most of the teaching program online. And here we are on different places. And did it feel that way? I mean, it felt we are all together, if even right now, right? So coming to the clinical part, COVID time taught us how to use technology from actually having a group of. I used to do family counseling. Remember, I never encouraged two people coming to me for for discussion, and the next day two new people will come. Third day, two new further people will come. You'll feel totally frustrated, and finally, no decision gets taken. In my practice, because as a palliative care doctor, we do deal with very seriously ill patients, a lot of complicated decisions to be taken. So I always tell my patients' family members, serious discussion is needed. Please bring all decision makers and we will have a discussion. I always keep extra chairs, plastic chairs you can stack up on each other, and whenever required we can spread them out easily. 10-15 people can sit in my OP room. I am particular about it that they should all sit. The sitting arrangements are in such a way, though it is not a very big room, but it is, I can easily accommodate. Why? Because I do not want to waste time, 20 minutes here, 15 minutes on a daily basis. I will talk to the family in one sitting. I may spend more time in that one sitting, but that one sitting is enough because everybody gets to understand what the problem is. Similarly, because I'm talking to everybody, nobody feels left out. Nobody's ego is poked. Oh, they did not call me. So the person who feels whose ego is hurt may be a very powerful person in the family who has a lot of nuisance value. So the family may come to a decision after discussion, but this person says, no, that decision is not good. We should think that way. Just because that person is irritated. So instead of excluding anybody, we include everybody who matters in the decision so that everybody hears the problem, discuss the problem all together at the same time. Sometimes some family member may come up with a question, and before I answer, some other family members who can answer that. So my job becomes easy. I don't have to talk a lot because I may become a facilitating chair, so to speak, about the family decision. Finally, after all the discussion, after all the questions asked, answered, finally we come to a decision by consensus. And thereafter, it becomes very easy. There is no two people coming to and talking to me on an everyday basis. Now, the same thing I could replicate online two ways. One was through our official telemedicine. We have, not every hospital has, but our hospital has a very good telemedicine department. So a lot of family counseling sessions. Somebody's in America, another person is Australia, somebody's in Dubai. There are one or two people in Bangalore, one person in Kochi, and everybody comes together and online. So online happened. Then there was other usage of WhatsApp group, patient group family members all in one WhatsApp group, and me giving a bulletin on a daily basis and some question answered. All of this is possible. So after this long explanation, yes, we embrace technology because technology enhances our ability to interact with human beings.
Thank you, sir. So many of us in different kinds of settings, we may have to deal with patients whom we don't share a common language. In such cases, how can we communicate news to such patients, or how do we just communicate in general with them?
Correct. So language can definitely be a barrier. Not just language, inability to speak. If you have a phasic patient or somebody who can't hear properly, all of these are barriers to communication. And as I said, the major part of any communication is body language. You may not be able to understand the nitty-gritty, for which you may need to wait for some time for a translator to come and things like that. But by and large, with one or two words and a lot of body language, you can, communicate fairly, well. For example, in Trivandrum, you have a lot of Maldivian patients, and I know one word of Maldives, that is Tadua for patient. And then, for example, I ask Tadua, and say, Tadua. Then they'll say a lot of things I'll not understand, and say, small Tadua, medium Tadua, big Tadua. So they also sometimes they laugh. Sometimes you can understand. Then there's a small Tadua, big Tadua. So basically, you get one word and rest 99% you make up with your body language, gestures, and you try to understand what's the problem. Ultimately, you want to solve the problem. So if you understand that there is Tadua and then there is a medium Tadua or severe Tadua, then you will get on and at least start doing something. You can find out the later things. You can wait for a relative who can speak English, or if you have a, if you're a big hospital, you may have translators and that kind of things. It is difficult, but if you have a reasonable command over your body language, a lot is possible.
Thank you, sir. Sir, earlier you had said that you should always ask the patient about what has their primary physician told them about the disease. Now, suppose we know with the reports which they have come to us that it is a cancer, but the primary physician hasn't told so. In such a case, what shall be our stand at that moment in time? Should we be the ones who break the news to them, or should we wait for the primary physician to respond?
I think we will talk about this on our next session, because we'll be talking about communicating bad news on our next session. Priya, when is this? Second, I understand. Second?
Yes, sir. Second episode.
Friday. Yeah, Friday we will talk about that.
Sure, sir. So that goes for another question as well, Dr. Jyoti. We'll be taking this up in the next session.
What was
sir,
the question? Yeah, same question.
Same question, sir. Sir, apart from that, in palliative medicine, are there any consents to be communicated or got signed by a patient? Is there anything like that in our palliative medicine practice? It's there a lot when it comes to intensive care, things like that, where we have to take consents and get forms signed by them. But in palliative medicine, is there some forms like that which we do?
Nothing specific to palliative care. For example, if you're in a hospital, the basic consents would be regarding admission, or basic consent for complying with the hospital rules and things like that for OP or IP. Then consent will be specific for certain procedures or operations and things like that. Some consent for specific investigations. For example, investigating for HIV, I think requires some consent, or COVID and things like that. Then there are consents for the financial consent for some procedures or IP admission and things like that. Then there is consent for foregoing critical care. For example, DNR, do not resuscitate, those kind of consents are there. So we operate across all of these consents, because sometimes our patient may have to undergo some procedure by some other department, they get consent, or our patient may have already had taken a consent, DNR consent from ICU, was admitted under, let's say, gastroenterology in ICU, taken consent for DNR, shifted under palliative care. All of these things are happening. But just for getting palliative care, I'm not aware of any specific consent.
So, sir, that brings us to the end of questions as well for this wonderful session. Any closing remarks from your end, sir?
Closing remarks from my end. I think I've been speaking so much. I think I'll leave it to you.
So, sir, this is
Looking
something
forward
which is,
to meeting all of you on Friday. My closing remarks.
sir, Wednesday, right? Session. Okay, okay. So, sir, this is something which is being emphasized to us since I think since first MBBS onwards, the way our preclinical teachers have trained us, and then this continues till we pass out, and then slowly as the line of our degrees, it increases, this aspect decreases and decreases. At least that's the general perception which we get from many of the patients who end up in palliative care. And we have to do the communication part of it right. Many a times they are at their towards the fag end of their disease, and then we are communicating something which should have been done much earlier. So thank you so much, sir, for reminding us about this. And I'm sure that the next session is going to be even more interesting, because how do we are going to be at that point where the patient is at a make or break stage. And that is the point where we are going to come into the picture many a times. And we may have to do a balancing act where we stop the reputation of doctors from being tarnished. And at the other hand, making sure that the patient is, we hold hands of the patient and take them forward in the treatment process. So I'm sure that the next session is going to be maybe many-fold up in level of complexity. Really looking forward to it, sir. Thank you so much, sir, for taking time out from your busy schedule. Shri Priya, over to you.
Thank you, Dr. Biju Raghavan. As usual, the basic concepts of communication communicated very effectively, I believe. Because it takes a lot of effort to communicate things over online, and most of our faculties, by God's grace, are doing the job wonderfully. I believe everyone in the audience will agree to that. So thank you, sir, for joining us. We do understand your day has not ended, that you are running back to your busy schedule. We do know that. So thank you for coming in between and spending so much time for.
Thank you. Thank you, both of you. You have been wonderful hosts, and thanks to all the participants who have been sending me compliments. I can still see compliments and thanks coming. Thank you so much. You're all elevated my energy. So I feel more energetic than when I started out. So thank you all of you for that. Have a good day. Take care. Bye-bye.
With the hope that we will see you again in the next part of communication. This is Shri Priya along with Dr. Biju Raghavan and Dr. Deepak Sudhakaran signing off from the Tips Eco Hub. See you in the next session. Till then, everyone take care. Bye-bye.